Good morning, everyone. Good morning. Good morning. Welcome to the Foster Together Network's virtual conference entitled the Solution Series, a national four-part virtual conference examining some of the biggest foster care challenges while building practical solutions. In attendance today is a broad cross-section of the foster care landscape, including representatives from the philanthropic community, government agencies, foster family agencies, community organizations, resource parents, as well as current and former youth in foster care. Throughout this morning's session, we invite you to use the Q&A button to type in your questions, and we'll address them at the end of the 60-minute panel. The Solution Series is made possible through the generous support of the Pritzker Foster Care Initiative, Center for Strategic Partnerships, the Big Orange Splot, and is produced in partnership with Raise a Child. To kick off the Solution Series for Foster Together Network is the CEO of Big Orange Splot and the Director of Foster Together Network. Ladies and gentlemen, please welcome Mrs. Rochelle Alley.
Good morning, everyone. It is my great pleasure to welcome you on behalf of the Foster Together Network and its home agency, the Center for Strategic Partnerships. The Foster Together Network is a vibrant collaborative that bridges governmental, nonprofit, youth, parent, and philanthropic voices to work together to improve the quality of care for foster youth. We are so grateful today and thankful to our partner Raise a Child for the incredible work that they have done to produce this conference, as well as grateful to the Pritzker Foster Care Initiative for their generous sponsorship. It's my pleasure to introduce to you today your moderator, Mr. Tyler Rinde, who is the Deputy Director of Child Welfare for the California Alliance of Child and Family Services. Tyler, take it away.
Thanks, Rochelle. Welcome, everyone. Really excited you're all here. I'll be the moderator for today. It would be difficult for anyone involved in the nation's child welfare foster care systems not to notice a foundational change that started in recent years, spurred by recent state and national legislation. Here in California, a foundational shift began to shake the foster care system in 2015 with California Assembly Bill 403, also known as the Continuum of Care Reform, with goals to reduce congregate care placements, increase relative placements, and then 3 years later, the federal government began to roll out new legislation known as the Family First Prevention Services Act. Raise a Child has assembled an amazing panel of foster care professionals for today's session one entitled Foundational Change, Understanding How Recent Legislation is Driving New Opportunity and Changes for Today's Foster System. Together, our panelists will help us move through a three-step process in the session. First, we'll learn about the origins and the logic behind CCR and the National Family First Prevention Services Act. Secondly, we'll examine the intended benefits and unintended effects of these two laws as they impact us in California and those joining us from across the nation. Then thirdly, we'll take your questions from the chat and together discuss solutions to the challenges that we're facing as related to these two laws. With that understood, I'm proud to introduce our panel of experts from across the spectrum of foster care. First, I'd like to introduce two panelists joining us from Sacramento, Diana Boyer, Director of Policy for Child Welfare and Older Adult Services at the County Welfare Directors Association, and then Angie Schwartz, Deputy Director, Children and Family Services Division with the Department of Social Services. Then joining us from Washington, D.C., please welcome Becky Shipp, Principal of Becky Shipp Consulting, and Lisette Burton, Chief Policy and Practice Advisor of ACRC, or the Association of Children's Residential and Community Services. And then joining us from Los Angeles, please welcome Charito Guerrero, Director of Resource Family Programs at Penny Lane Centers. First, I'd like to turn to Diana and ask a couple of questions to kick off the panel. I understand that you and the County Welfare Directors Association were very involved in the 2015 passage of AB 403, Continuum of Care Reform Act. I have a couple questions for you. Can you please quickly explain what is the County Welfare Directors Association and how is your association involved in the formation and passage of CCR?
Thank you, Tyler, and thanks everyone for being on this webinar. Appreciate the invitation. So California is one of just a few states where our child welfare program is administered by counties. And so in that respect, the County Welfare Directors Association, or CWDA for short, represents the human services directors from each of the 58 counties that are administering various public benefit programs that include child welfare, foster care, as well as TANF and other programs. In my role, I work with the state agencies to facilitate implementation of laws. We sponsor and we lobby on legislation and state budget issues, both at the federal and state levels. And importantly, we bring together all 58 of our county directors on a monthly basis to discuss challenges, opportunities for advancing the work on behalf of children, youth, and families. So how did we get involved in CCR? Well, we used a very unique opportunity during the Great Recession of 2009 to kickstart our reform effort. At that time, we had some major budget deficits to address. And so we essentially realigned the funding for our programs down to the local level. But with that, we saw an opportunity to readdress our foster care system, to make it more attentive to the needs of the children and families we serve. And so we worked with, initially we passed a legislation that essentially changed the terminology from congregate care reform to continuum of care reform, where we realized that in order to address congregate care issues, we really needed to attend to the needs of children and families in family-based settings. So that kickstarted a number and series of work group meetings that were attended to by various stakeholders, many stakeholders, attorneys representing kids, foster family agencies, group home providers, family-based caregivers. We at CWDA co-led a steering committee with CDSS, our Department of Social Services lead, to develop a set of recommendations. Those recommendations were also informed by CWDA partnering with Tyler's group, the Alliance of Child and Family Services. We developed a white paper that addressed our vision for what we wanted to see, that we brought to the steering committee, and ultimately was adopted through the legislation that led to AB 403, which was our continuum of care reform effort.
Thanks, Diana. Next question is asking, what were two of the most important goals that CCR was designed to address? And then, from your perspective, what are two challenges that counties have experienced throughout CCR implementation?
All right. Well, certainly the two primary ones were to reduce the use of congregate care. And when we ever needed to use congregate care, to make that a short-term intensive services and supports option, therapeutic option. We even renamed our group homes to short-term therapeutic programs. And the other goal primarily was to increase our family-based use of services, especially with relative caregivers. Now, in our specific law, we actually also had three other explicit goals. One was to use more comprehensive child assessments early in the child's case. Second was to provide services and supports directly in those family-based settings. And third was to create more timely pathways to permanency, both for child welfare involved youth as well as our juvenile justice involved youth. Now, I can't get into the challenges before I say a few of the successes, as I do think they tie into each other. So when we implemented CCRs, we gave ourselves 2 years lead time to make all these changes. At that time, we had 5,100 kids in congregate care. Now we have less than 1,700. It's been an amazing and precipitous drop in our use of congregate care. It's around a 60% reduction. Our initial placements into care with relatives has increased 24% for child welfare involved youth, and even more by about 50% for our probation involved youth. All of our kids are now getting a child and family team. That wasn't the case before CCR. They're getting that 60 days upon entry into foster care, regularly thereafter. We're all utilizing the Child and Adolescent Needs and Strengths Assessment, or CANS for short. where we've actually implemented a family urgent response system that came right after CCR, but it was intended to be a support to CCR. It provides in-home crisis support to foster children, current and former foster children, and their caregivers. We've implemented intensive foster care services, updated our foster care rates, increased those rates, and made significant changes to our foster care approval process to better support families. So it was a number, it wasn't just one primary change. It was a number of changes that altogether were intended to be woven so that we were achieving those outcomes that our goals, as I stated earlier. So that brings us to our challenges. Yes, it has not been without its trials and tribulations, as we say. One of the first things that we recognize is we have a lot more work to do to be more trauma informed and to align our case management approaches, our direct supports and services, and our resources to address that trauma. We recognize we need to be more upstream. We know right now, as we know, the ACEs study, we know a lot more about trauma. We know that has an impact on physical and mental health and well-being, that has a very pronounced impact for kids in our system, especially. We know the impacts of trauma on brain development and its later manifestations, and we've known about child and adolescent development and attachment. Yet our assessments continue to fall short of giving us that complete picture and history that will ultimately allow us to deliver the appropriate service and supports to both children and their caregivers. In other words, we're not getting to the root cause still of why children and families are coming to our system in the first place. We continue to put on Band-Aids on a wound that's much deeper than we are looking at now. And I believe there is work underway. And I believe it's a unique opportunity and moment in time that I'm excited about to pull a lot of this information together and improve our upfront assessments and our services that we deliver. But we also need to ensure that our county social workers, our local agencies, and our partner providers, our mental health clinicians, and many others are aligned with us, are on this journey with us and working together to appropriately respond and serve families. So that's our first challenge. It's a big one. Our second challenge, and I'll be shorter here, is just because I know Lizette's going to cover and speak to some of this later on, is that we have a lot more work to do for youth with complex trauma, those that are served across multiple service systems, including our developmental services, special education, behavioral health, and physical health services. Our reform effort didn't explicitly try to address that group. It's the group of youth that we often see are quickly overwhelmed when they enter a residential placement that may need something that's a higher level, like a psychiatric type of facility, or who are hospitalized many times. There are efforts underway in California to address it. I could speak to that later. But I will just say that it is work that we are really just starting to roll up our sleeves now to try to figure out, and it will take time to see those improvements.
Thanks, Diana. Next, I want to transition over to Becky Shipp. So as California was finding its footing with AB 403, you were working with Republican Senator Chuck Grassley, then the chair of the Senate Finance Committee, in a bipartisan effort to draft and pass some of the first national foster care legislation in a couple years. In a few minutes, will you please share the key purpose and goals behind the Family First Prevention Services Act that came out of Washington in 2018?
Sure. Thank you. Thank you, everybody. Thank you, Tyler. Thank the rest of the wonderful panelists we have here today. The Family First Prevention Services Act was really informed by about a decade's worth of working sessions with current and former foster youth, parents, advocates. You know, we began our work with a call to action, having heard from a number of these current and former youth. And a lot of times when they were asked what could have helped your experience in foster care, not every time, but a lot of times they would say, you could have helped my mom. If my mom had been able to get the services that could have helped her mental health or substance abuse problems, I wouldn't have had to go into foster care. So you could have helped my mom. That was a refrain and a theme that we heard over and over again. Additionally, we heard that some youth were inappropriately placed in group homes as opposed to a family foster care setting. That does not negate the need for facilities to address, as Diana said, youth with incredibly complex situations. But there were a number of youth that were inappropriately placed. So the theory of the case, where we heard from a number of states, is if federal resources could be directed to upfront services, and we can talk a little bit more about what's upfront and what opportunities exist for expanding that. But if there could be some federal resources directed to prevention services, that could ultimately reduce the number of children and youth who need to go into foster care. The verdict on whether or not that theory of the case is valid or not is still to be determined. But the theory of the case, the philosophy undermining Family First, was directing federal resources to what works, i.e. prevention services, and reducing federal resources for inappropriate congregate care placements.
Thanks, Becky. And I want to transition to asking, what are two successes that you're seeing in states across the country right now? And then I guess, what are two challenges that you're seeing in states as FFPSA has rolled out over the last couple of years?
Okay. Well, I would be remiss if I didn't note that the trajectory for Family First to really take off the ground has been somewhat delayed by the COVID-19 panic. What we've heard is that a number of child welfare service providers and child welfare caseworkers who were tasked initially with working to implement Family First were taken off of that and having to sort of do triage to address COVID-19. But what I see right now are sort of the positives sort of come from bigger picture. I think for folks are rightly taking a look at child welfare systems writ large and some of the implicit biases undermining a lot of assumptions in child welfare. I think there's a renewed focus on normalcy as a key aspect of the foster care system. I think that it's critical that states are sharing best practices as they grapple with the implications of Family First. I think part of where our challenges are the actual details relative to Family First. Lizette will talk a little bit about this, but there's a arcane provision in Medicaid law that restricts federal reimbursement for certain facilities over 16 beds. It's called the IMD exemption. That is having real implications on the qualified residential treatment programs, the group homes that are permitted under Family First to receive federal reimbursement from getting reimbursement, and it's causing a lot of consternation and concern. And then there's also the not really accelerated rate that prevention services have been approved for federal reimbursement. So sort of big picture, good talk, good thinking, details, devil's in the details. Those are a little laggy in my view.
I think you kind of touched on the next question I was going to ask right at the end. With prevention services, it's taken a time for them to roll out. I know California, I don't believe we have our approved plan yet, but want to ask you kind of what do you see as the opportunities moving forward for, an expanding prevention services?
I mean, when Family First was being developed and was being sort of shopped around, there was a very valid criticism that in order to receive prevention services, a child has to be a candidate for foster care. And what that means, and it was a rightful criticism of the bill, was that some type of neglect had to have occurred. What we should be working for, and that's an opportunity that's not just going to fall in folks' lap, that's going to have to be created. But what is truly needed is trying to crack the code on how you get these prevention services upstream before prevention, before abuse or neglect ever happens, to really sort of figure out how to reach families before there is a critical need.
Thanks, Becky. Want to transition to kind of a local questions with Chorito. So asking more of, with their foster family agency and kind of experience of complying with the two different laws. I think we'd like to, sorry, I got just, from the perspective of a foster family agency, can you be specific as to two of the biggest successes that foster family agencies are seeing as a result of CCR and Family First? And then what are some of the challenges that you've seen here in California as a foster family agency?
Thank you, Tyler. Good morning, everybody. As previously stated, my name is Charito Guerrero, and I'm the Senior Director of Resource Family Programs at Penny Lane Centers. And our agency has various locations spread out all throughout Los Angeles County. I want to start first by thanking everyone that's here for your willingness to share information, learn from one another, and really consider ongoing ways to partner together to tackle the issues that are impacting our children, youth, and their families. My experience is very specific to Los Angeles, and it's important that state that for perspective, so you understand that other geographical locations, other areas may be having a very different experience than the one that we're having here in LA County. I've been working in foster care for a little over 12 years, and in that time, I've really been able to witness the changes and challenges in our work with our resource families, children, youth, and their families. Going back to your question, though, Tyler, about two of the biggest successes that we've seen as a result of CCR is that first, there's definitely been more of an effort from child welfare agencies to find relatives for children and youth involved in child welfare. We've been able to see the positive outcome of children and youth connecting with relatives that they're close to and reunifying with extended caregivers. I would also say that another second positive outcome is that we've been able to partner with our local DCFS, the Department of Children and Family Services, on a particular project regarding CCR and the efforts made towards supporting relative caregivers. Our agency is in the unique situation to be able to offer, not just our foster care services to our resource families, but also offer relative support services to relative caregivers. Being able to really help these relatives navigate the system and get a better sense of what resources are available to them has really been a great opportunity for us. Unfortunately, as we've all highlighted and stated, no decision comes without its consequences. And we've also seen that there's been a change in the landscape of child welfare. We're seeing a much higher need for resource families who can work with older youth, larger sibling sets, and children and youth with more specific needs such as trauma and behavioral support. As an agency, and as many agencies have experienced, we've really had to refocus our recruitment efforts and the supports that we offer to our resource families working with these children and youth. In addition, although CCR really aimed for a uniformed process for resource families, that hasn't really been our experience, nor the experience of other agencies that we've partnered with. Private agencies continues to be held to a much higher standard in providing services for the approvals and such, while relative caregivers with our county are not. It makes it challenging to meet the ongoing demands as a private agency due to the requirements that we have to meet. And switching gears to talk about the Family First Prevention Act, we're involved in several groups and meetings and efforts who are looking at how this will unfold and what the impact will be. But overall, there's been a lot of teaming, as some of my colleagues have mentioned, a lot of collaboration, which has been really incredible to witness how everyone's come together to really focus on how we can truly implement it. As an agency, in preparation for all of that, we've really also had to look at what evidence-based practices are we offering and how do we improve our toolbox and evolve it to be able to meet the requirements of the Family First Prevention Act.
Thanks, Charito. Next question for you. Penny Lane closed their group homes at a time when children and youth in foster care were then being housed overnight in hotels and county offices. There are rumors that FFAs around the state are having discussions of whether it's feasible to continue operating their foster care divisions. Are you open to speaking about why some of the foster family agencies may be having these kinds of discussions?
You know, our group home and residential care programs were supervised by someone else, but I can't provide a lot of detail, but sort of what I was privy to is that losing our group homes was challenging on a lot of levels. Not only did we lose very committed and passionate staff that serviced our youth for a very long time, but we had nearly a 50-year history of providing great care to the youth that we had in residential care. Penny Lane's beginnings were born with a group home, and it was very difficult for us to decide to close them. As an agency, we had to really determine whether or not we could realistically provide the services and meet the requirements of this new vision around group homes. And unfortunately, after much deliberation, a lot of discussions, we felt that we would no longer be able to do that. And we're obviously trying to look for new ways of growing and evolving and being able to continue to provide services to children and youth who need them under this capacity. But Penny Lane, like other agencies, really have to determine if it's feasible right now. So it's not surprising that the sense is that many agencies are finding themselves in the same situation that we were in about a year ago when we closed.
Thank you. Next, I'll turn to Lisette for a few questions with ACRC. There's countless TV and newspaper reports all across the country about children and youth in foster care having to spend their days in offices and at night sleeping in offices or motel rooms with social workers. Lisette, from your position at the Association of Children's Residential and Community Services, is this a trend of the pandemic, the new legislation, or a combination of the both, or something else?
Thank you, Tyler, and thank you everybody on the panel. It's I appreciate that we're having this conversation, and I would actually say, to your question of whether this is being caused by the pandemic or by new legislation or both, I would actually say neither. The fact of the matter is, young people being housed or staying in hotels, offices, boarding in emergency rooms, which isn't just a problem for young people who are in foster care, but for young people across the country. And actually, we're seeing that around the world. Young people experiencing night-to-night foster care placements in some states, young people overstaying medical necessity in psychiatric facilities. All of those things were happening well before the pandemic and well before Family First was passed. So it's an ongoing challenge to create continuums of care that meet the needs of young people and families and communities. And that said, I do think that the pandemic has exacerbated the problem in the same way that there's been lots of conversations about a crisis in youth mental health not being caused by the pandemic, but being exacerbated by the pandemic. I think we're seeing the same thing with how we are serving young people and families who are involved in child welfare systems. And the issue that's been exacerbated is access. So with the pandemic, if you think about everything that shut down, we had foster families, understandably, maybe unwilling or hesitant to bring somebody into their home for good reason, right? Based on all of the health information that we were being told. We had program providers who were STRTPs in California, by any other name, elsewhere, who were having to create quarantine units, so not able to serve perhaps as many children as they would have been serving otherwise. And so all of those complications created bottlenecks to access that exacerbated an already challenging situation. And in general, if we're talking about legislation and the impact of legislation, whether it's continuum of care reform or Family First, one, I would say any big piece of legislation has lots of implications, some foreseen and some that were unintended. And so there's always, I think, with big new policy changes that are impactful, opportunities or thought that needs to go to what do we tweak, what do we change, how do we respond to things that maybe we didn't expect. But the bottom line is, if we talk about the legislation that you've heard about, that Diana has described and Becky has described and Teresa has explained how her agency has been a part of that, those are all things that are trying to move us in the right direction. I think specifically when we talk about young people in foster care and what our child welfare systems look like around the country, something to think about is, as we do a better job of doing the right thing, right, narrowing that front door, not separating families and removing children who don't need to be removed, supporting families more on the front end, ideally before there's even any system involvement at all. There's some research that goes back, again, well before the pandemic, well before any of this legislation was passed, in the Journal of Pediatrics. If anybody wants the citation, I can send it to you. It's from 2013. And it talks about the fact that as we do a better job of narrowing that front door, what we're seeing is a smaller but more complex population of young people in foster care who have different needs, right? And so what we really need to be thinking about is, how are we, or how are we not, redesigning our systems for this new purpose that's different from maybe what our systems were designed for 10, 20, 30 years ago.
Thanks, Lisette. And just want to transition back to what Becky said earlier. She kind of alluded to it, that one of the kind of unintended kind of challenges with FFPSA was related to the Institute for Mental Disease law back from 1965. Just want to see if you can talk a little bit more about kind of what that implication is, and then kind of what ACRC is working on in this area.
Yeah, and so this is complicated, and I understand that we might have listeners who know a lot about this, and I see there's a question in the Q&A about it from somebody who's very well informed, clearly, and some people who might have no idea what these letters are that we're throwing out. And so IMD stands for Institution for Mental Diseases. As Becky mentioned, this is an exclusion that goes back to Medicaid law from 1965. And because this applies to, a threshold question is an institution, and there's all kinds of questions about how do we define the institution, but if an institution has more than 16 beds and serves people, individuals, this applies to children and adults, but we'll talk about it in the context of children, with mental and behavioral health needs, there's a potential that that facility can be considered an institution for mental disease, which means that Medicaid, federal Medicaid dollars are not available to support that individual's care needs, whether that's their mental health services that they might be receiving in a facility or any other medical health needs. And so that's a complicated interaction. And the bottom line is, child welfare experts around the country, as they've been building systems, have not necessarily been focused on what the interaction with Medicaid is, right? That wasn't their role. They were trying to build effective systems to better support young people who come to the attention of child protection systems. And so, it's complicated. It's created, I think, a lot of, Becky said consternation. I think a lot of confusion. Different states are approaching this in different ways. But the bottom line is, in California, I know there's been investments to help providers reduce down to that kind of 16-bed threshold, which some providers have been able to do and other providers have found challenging. In some other states, there are efforts to just use state dollars to pay for those services, because there's a recognition that that's an important part of the continuum of care. And the state has said, we're just going to find a way to pay for it. So different states are approaching this in different ways. It continues to be a challenge. I think the bottom line is that all jurisdictions, all states really should be looking at, what do we have, what do we need, and how do we best meet those needs, and building a continuum of care that addresses those things in that way.
Thanks, Lisette. Before we go to Angie, I did want to come back to Diana and ask her similar question around FFPSA and kind of what are you seeing as the impacts on the ground, particularly related to what we were just talking about with the IMD and with some of the new requirements for admitting to residential.
Well, I'll tackle the IMD issue first. I will say that we are concerned that we are seeing some facilities that are choosing to go into a different line of work, frankly. And we're losing some really great providers. And I think it's in part because of the worries around whether or not they would continue to get the Medicaid funding for the kids that go into these institutions that are deemed IMDs. I think it's because of the very difficult youth that are now being served because of our investments in family-based care. We've reduced kids that go to congregate care. Those kids' needs are very much more acute, coupled with the fact that we have workforce challenges up and down our system of care in our county child welfare agencies as well, especially with our family-based providers and residential providers. And so we're struggling there and trying to work with our state partners on that. And we're very grateful for Becky and Lizette's leadership at the federal level on this issue, because we have been trying to tackle this. With respect to the other part of Part 4 FFPSA, the qualified individual assessment, I mean, just very briefly, as most people may be aware, there's a requirement that the federal law requires a licensed clinician, trained professional to conduct an assessment for any youth that's going into a residential care setting, called the QRTP, another fun acronym, and to make certain determinations and to work with the child and family team to determine what kinds of services can be provided if that child needs to be in a residential setting. Very importantly, the federal law is very explicit that the lack of a family-based setting cannot be used as a justification for QRTP placement. Well, lo and behold, at the same time, we're also facing shortages of foster family providers, right? So it's very difficult for us sometimes to meet the requirements in this section. We also have a shortage and a workforce issue around clinicians as well. So clinicians that are being asked to do these very in-depth assessments are being pulled many directions because we're also needing to provide services. And when that QI may recommend a service, that service may not be readily available if it's going to be in a family-based placement. So there's a lot of challenges still to work out. We're trying to assess out whether these are short-term or longer-term issues. I do think on a longer-term need for our QI is really to figure out sort of how we build consistency, especially in a state like California with 58 counties, consistency across the 58 counties in the QI assessments. We have some tools, we have some training, but we really don't know what the quality is of those recommendations that are being made and how consistent they're being made. We're also trying to avoid over assessments of these youth. And what we find, because in part of this crisis that we're facing in the continuum, kids may change placements. That means they're doing assessments over and over and over again. And so there's still a lot of challenges for us in California on implementation.
Thanks, Diana. Next, want to go to Angie. Even before joining the Department of Social Services, you were involved with the formation and the passage of both the laws that we've been talking about. Want to ask you if, from where you sit now at the state, can you share an analysis of how California is navigating the convergence of CCR and Family First? And then are there aspects of the law from your perspective that, conflict, and where our success is?
Hi, sure. Good morning. Nice to see everyone and to hear the discussion this morning. I think Diana gave a really good history of the two laws and noted that California kind of got a head start on the feds with our approach to trying to reduce reliance on congregate care and make sure kids are in family settings whenever possible. And so CCR was about 10 years before, at least the initial work of CCR was about 10 years before the passage of Family First. And I don't necessarily think they're in conflict. I think Family First came behind and was trying to do much of the same thing, but not necessarily with all of the same tools. And it was actually an opportunity for us to iterate a little on what we had already done, particularly with what we had already done around reduction of congregate care. Family First included some provisions that were not initially included in our approach to CCR. So it required us to have assessments by a qualified individual in order to assess whether or not a young person should be in a what we call STRTP, what the federal law calls a QRTP, And that was new, so we had to figure out sort of how to do that. And I think we are still trying to figure out exactly how to utilize those qualified individuals. But we see real value in trying to have sort of a assessment, an individual assessment, and make sure that we are really doing that planning, that treatment planning, and sort of understanding the youth trauma and needs as we're making those placement decisions. I think Diana also talked about the fact that what we are seeing is the need to really do appropriate assessments of individuals, and the QI can be a piece of sort of understanding what those young person's needs are. And so I think there is an opportunity there. I don't know that we've completely hit on the right way to utilize the QI in order to make sure that we're truly understanding the trauma history of young people and meeting those needs of young people. But I think it's pushing us in that direction, which is not a bad thing. Family First also required us to have aftercare services available, which is something that was part of the RBS pilot that sort of preceded CCR, or the residential based services pilot. Sorry, I speak in alphabet soup. I realize not everyone knows all of our acronyms. And, you know, something that I think Diana spoke also about the fact that we were in sort of a different economic situation when we were initially putting the CCR reforms in place. But the provision of aftercare services, I think, is tremendously important as we're thinking about how to step young people out of residential settings and into family-based care. And so having to add that into our continuum is a good thing. It also required us to sort of introduce a nursing component into our STRTPs, or what the federal law calls QRTPs. So they're not necessarily in conflict. It required us to sort of put in place pieces of the reform that had not been in place in our initial version. But I think we're finding that there's opportunities in adding those things to our approach, and allowing us to continue to try to figure out like where are the continued gaps so that we can better meet the needs of young people.
Thanks, Angie. This is kind of what came up earlier was, talk about youth with unmet complex care needs. So I want to ask you about, what is the state doing and tackling in this area to meet, the challenges of youth with unmet complex care needs?
We're doing a lot, and it is a particular challenge. I mean, I think, as a result of sort of the success of CCR and also of the initial implementation of Family First, someone said, we've had a 50% reduction of youth in congregate care facilities. That's to be celebrated. We've had a tremendous increase of youth with first placements with relatives and predominant placements with relatives. And that's a really good thing as well. Those kids tend to experience less trauma over their time in care, and a lot more placement stability, and sort of don't become the population of young people that have unmet complex care needs. And so those are all really good things that have resulted from CCR. But we still have a population of young people that do have significant needs. And now those groupings of kids are kind of together in often in settings where they need to have much more individualized attention. I mean, interestingly, we're talking about the IMB rule and having to sort of reduce capacity below those 16 beds. But what we're also finding is the kids that are left to be served in our residential treatment facilities actually need even smaller, even more individualized type settings. And so I think the challenge that we're facing right now in some of the work is that the business models that are in place that allow an organization to actually function as a residential treatment facility, and how that young person actually needs to be served in order to really benefit from that treatment and be able to be in a family setting and transition into a family setting, are a little bit at odds. And so we are innovating in California around how do you fund and support more innovative models of care. So we're considering things like STRTPs of 1, like much smaller than 16 beds, like STRTPs of 1, STRTPs of 2, right? How do you get to a much more individualized, truly intensive type of treatment support for a young person? But how do you also do that within a rate system, within an organizational system that allows that organization to continue to be able to function, month over month? And so I think we're starting to grapple with some of that tension. We've got a rates work group that's or actually 4 different work groups that have been meeting over the last many months to sort of reflect on how have we been funding all of our placements across our entire continuum in California, and look at what we put in place at the beginning of CCR, and where have there been gaps, where have there been successes. Let's not throw out the things that are working, but where are those gaps in terms of how we are actually funding the continuum of settings, or the continuum of services. You know, I think more and more we're also realizing that we need to be able to innovate around meeting the needs of the youth wherever they are, and not have it so placement based, to not have it so much based on where the child is quote unquote placed. But really, I think Diana spoke to this, and Lizette spoke to this as well, understanding what the individualized needs are of kids. So instead of having a placement first approach to foster care, have a trauma first approach to foster care, understand the young person's trauma history, understand through appropriate assessments and tools what that young person really is going to need, and then be able to provide those regardless of the type of placement the young person ends up in. And so, you know, I think it's forcing us to grapple with how do we truly serve the needs of young people and meet the needs of young people. And we should be able to do that in a variety of different settings. It shouldn't have to be so attached to a certain type of placement.
Thanks, Angie. Next question, and you touched upon this, speaking about residentially based services, or RBS. So yeah, as you mentioned, prior to CCR and to FFPSA, California was innovating with RBS, you know, which included intensive family finding, engagement, extensive family inclusion, ability for crisis stabilization beds. And you mentioned one of the ones that was included, which was aftercare in Family First. So want to ask you about, since a lot of this was not included in CCR and FFPSA, what are your thoughts now on, you know, some of the tenets of the RBS model? And then, you know, is that something that the state could look towards kind of in the future as well?
Well, so I mentioned we have the rates work groups that are currently meeting. So we're actually, and that was intentionally built into the original CCR legislation, I should say, like that those are interim rates that were created, and there was always an intention that we would re-examine sort of what we put in place and whether or not it's working, and then move towards, you know, a more final system of how we're actually going to fund both the care and supervision and the services that young people need. I mean, I think there were a lot of things as part of the RBS pilot that weren't included in the initial set of CCR reforms, some of which have been included now because of requirements that have been placed on us as a result of Family First, and others that probably we need to continue to sort of re-examine and look at what else do we actually need to have in these settings. So I don't know that it's exclusive to what we learned from RBS, although we should certainly go back and look at what we learned from RBS and see if there aren't things that we can incorporate into our system now in order to do a better job of serving young people. I think we've also had tremendous innovation that's happened at the county level, and we need to learn from like where are counties finding the most success and where are they figuring out how to really support young people in innovative ways. And some of that is what I was just talking about with like smaller approaches to treatment facilities, and how do you actually fund and scale that type of setting. And that goes, you know, I think beyond what we learned through the RBS pilots. But we have a lot of different places in California where we're having these conversations and trying to bring the right group of folks together. I think one of the things that we're doing well is not thinking of it exclusively as a child welfare problem. We think of it as a system of care problem, and are trying very much to bring our healthcare partners and our behavioral health care partners and our developmental services partners and our education partners to the table in order to say, these young people that have these unmet complex care needs within, you know, our system are also served by your systems. And so we collectively need to figure out how to address the needs of these young people. I think that also goes beyond what RBS was doing, which is really looking at it more as a child welfare problem. And I think one thing that we've really learned over the last 10 years is it's not a child welfare problem. It's a system problem, it's a system of care problem, and we actually really need to address these issues as a collective system of care. And so I think one thing that California is really trying to do, we've created a system of care branch within the Children and Family Services Division. And then that system of care branch is making sure to sort of reach out to all of those other partners and innovate around solutions that are not specific to our space, but actually utilizing their resources, their expertise in order to create solutions for these young people and families.
Thank you. Last question for you. What would you say to Torito and to foster family agencies that are doing their best to provide critical family-based care and then stay relevant as the landscape of foster care continues to change?
Well, I would agree with Terito that one of the successes has been around our placement with relatives, and we are continuing to really focus around how can we get children immediately connected with their own family members and supported in those settings. And I think the FFAs are a key to that support within those family settings. And so just speaking a little bit about how they have been able to do those relative support services within Penny Lane's FFA. And I think we've had that success in other parts of the state, but we haven't really integrated that as part of our model. That is really just an expectation and how we are thinking about how we fund and support and set up the structure of an FFA so that counties are really able to utilize that resource in order to more effectively serve our kinship families. So as we continue to focus, which California is, we've got recent investments that are really putting more funding available to counties, as well as creation of a center for excellence that really is focusing on immediate placements with relatives. But I think as we are doing that work, we are also finding that it's not about finding them, and it's not necessarily just about that placement. It's also about robustly supporting those families and how can we partner with our private foster family agencies in order to be that support entity so that counties are also doing the work that they can do, which is finding the families and improving the families, and sort of how can we create these partnerships so that we are serving sort of all of families' needs and not necessarily duplicating efforts, but actually leveraging each other's resources and expertise in order to more effectively serve families. So I would say hang in there. We've got the rates work group going on right now where we're actually tackling these very specific questions and trying to figure out how to build the right sort of system of supports for our families in order to achieve our goals. But, you know, I think child welfare is always a place where you're sort of doing it and building it at the same time, and it can create some really uncomfortable tensions because, you know, we don't ever get a break from actually, we never get to hit the pause button on serving kids and families that are in crisis. And so as you innovate, you are continuing to have to serve families, and that can create these moments where you're like we haven't quite figured it all out yet, but we are always in the process of trying to figure it out.
Thanks, Angie. So the last part of the panel today, we have just a few minutes left. So this is the Solution Series Conference. So I'd like to revisit each of our panelists to get a suggested solution to some of the challenges that we are faced as a result of the two laws and kind of the entire dynamic of coming out of the pandemic and inflation, workforce shortages, and the other things that we're seeing that folks have discussed today. So we have about 7 minutes left. So if you can keep your answers brief, but I'll start with Diana with from a county perspective, what is one solution or thing that you're looking forward to that could help address some of the challenges that you're seeing at the local level?
Well, workforce challenges notwithstanding, because I do think we're going to have to address those. I 100% agree with Angie on this, and that's why our state and county partnership, I believe, is getting so much stronger than ever. We need to become less siloed between placements and between systems. And in order to do that, we need our FFA providers and our residential providers, care providers with us at the table on these solutions. We're evolving, but in good ways. So maybe less placements in foster care. I think ultimately, again, the way to address some of these challenges is ultimately to keep kids out of foster care. We know as a system, and we have to acknowledge that we can be damaging to children and families through that separation and loss. We also learned during the pandemic that once we gave concrete supports to families, we did not see those families come to our attention. Families and kids can be the agents of their own change and solution with support from our systems. And I want to say just that FFPSA Part 1 gives us that opportunity. Never before have we been able to spend Title 40 money on services. We also know through the great work of Chapin Hall, Claire Anderson, if you haven't seen that, happy to send information on that, but that investments to reduce poverty, such as the EITC and guaranteed income, have a direct correlation with reducing the incidence of abuse and neglect for kids. I think as a system, we need to move towards a greater emphasis on well-being. You hear the safety, permanence, and well-being piece so often. I think we need to focus on child and family well-being, not forgetting safety, of course, but looking at the context of that child, the child in the context of their family. I think ultimately, between what we know in terms of how we assess for families, and directly providing the power to children and families to be agents of their change, and giving them the resources and tools that they need, as well as our agencies need, I think we could really move the system forward.
Thanks, Diana. Becky, from your perspective, what's, next steps or a solution, for from your national kind of perspective for states?
Sure, thank you. This has just been, let me thank the rest of the panelists. This has been really very informative and exciting, and thank everybody for the wonderful insights and comments. I can speak with some authority that Family First was not intended to be the be-all and end-all of child welfare reform. It was a small first step, but it was a first step. And there were a lot of really good things that got left on the cutting room floor, most notably what Diana just mentioned, concrete services. And for those, it's not an acronym, but it's where you provide an actual resource like a washing machine or a childcare provider or an electric bill that is a preventative service that can keep people out of the child welfare system. That is absolutely something that was, again, it was included in an earlier version of Family First and had to be dropped for a number of reasons. So we need to kind of go back and pick up what was left on the cutting room floor and reassemble that. We also need to figure out a way to expand and bring to scale the upstream prevention services that that a lot of states have been doing. That is a challenge. One of the things that we haven't talked about that is really sort of deep end of the geek pool is how an entity called the Congressional Budget Office factors into a lot of this. They are the ones that sort of tell federal lawmakers basically what can and cannot happen in a bill because of the costs or savings associated with it. That presents a challenge moving forward, but it can be, I believe it can be cracked. I do believe personally that upfront upstream prevention services work, that they really can prevent children and youth from having to go into foster care. We just have to prove it to the satisfaction of the Congressional Budget Office, but I think it can be done.
Thanks, Becky. Lisette, again, from your perspective, how can we solve the acuity crisis and lack of appropriate placements for complex youth in foster care, and then any other solutions that you see?
Yeah, no, thank you for that, Tyler. And I really do think, Angie took the words out of my mouth, and maybe it's because we've been on panels together and I think we have some aligned thinking. We really should be talking about purpose, not placement. And so just as a quick example, New Jersey has a children's system of care. Everybody comes through that same door, regardless of who the payer source is. So if a young person needs behavioral health services, they come in through the New Jersey Children's System of Care. If you've ever heard Liz Manley talk, Liz Manley was around as the New Jersey Children's System of Care was being developed as a statewide system, and now she's at the University of Maryland. But she talks about how getting rid of that perspective of placement as opposed to intervention, which is really what residential is. It's really what stranger foster care is, right? It's an intervention. We're intervening with the family. If we can shift that thinking, then we have better conversations about, again, what do we have, what do we need? And so in terms of solutions, I think we continue to focus on lived expertise. We ask young people and families and communities what they need and what they want. There's been, I think, a lot of shift to that. If anybody participated in the Child Welfare Virtual Expo that was hosted by the Capacity Center Building for the States, You got to hear a lot about ways and strategies to incorporate lived expertise in the work that you're doing. So I think that's critical. I think that cross-sector holistic approach is absolutely key. And I'm glad to hear, Angie described what that's looking like in California. I think other states are starting to explore that. And I think without that, in the same way siloed funding leads to siloed programming, right? If we're having siloed conversations, we get siloed solutions that only pick off at bits and pieces. And I know what I end up hearing then is we think we've solved the problem, say in our child welfare system, but it turns out that those children are just being served by perhaps a juvenile justice system or an education system. So we really need cross-sector thinking. And then the last solution I think that will probably lead up to the next part of this solution series is relates to language, and language matters. So just like I talked about purpose, not placement, even the language of how we talk about resource parents or resource families versus foster parents, it implies a different reason for engaging and being, right? The old kind of request for foster families was, do you have love in your heart, space in your home, right? The request now really is about, as Tarita described, we're looking to serve sibling groups. We're looking to serve older young people. It really is, yes, love in your heart, space in your home. But do you want to be a change agent in the life of a child and a family? And are you willing to learn skills and engage in resources that will help you do that? And so as we think about redesigning things to meet the current need, wherever you are, whatever your system looks like, thinking about how you're talking about the work can help guide, I think, the solutions that people come up with locally.
Thanks, Lisette. Charito, what improvements do you feel are necessary for foster family agencies to continue serving children, youth, and families?
So much of what I was going to share has already been shared by, most of everyone on this panel. But just to reiterate it, I would say the first thing that would make a big difference as we continue the conversation is to have more parity among agencies in the counties that we work with, having continued more open collaborative conversations to create a uniform process for approvals and supports of the resource families. There needs to be engagement, continued engagement on both sides of the table to find creative ways of supporting children, youth, and families. And when children and youth are unable to be in a family home type setting and residential treatment is necessary, just having continued conversation about how to engage the family to support the children and youth in whatever type of setting, is going to work for them. And that's already outlined, as someone else mentioned, as part of one of the goals of the Family First Prevention Services Act. In addition, I couldn't agree more with what Diana was saying about having more of a focus on trauma-informed care. And I have to say that I think this really includes considering the entire picture when it comes time to make a decision about the permanency or plan for a child or youth. I think that the assessments for relatives available needs to actually occur much sooner. I don't think any of us would disagree with that. And I really say that to try to avoid trauma for our children and youth. We've had several cases, not to get into details, but just as an example, of children and youth who were moved after being with resource families for sometimes over a year, sometimes two, to relatives that came out of the woodworks, like the mother's cousin's brother's neighbor. And as you can imagine, that in and of itself, being with the resource family for that type of time or that length of time and then being moved, that in and of itself can create trauma. And so I think that we need to, as we're looking, forward and ahead and finding solutions, really looking at the big picture and what will be less traumatic, what is in general in the best interest of the child, and is it really to find a relative that's a fifth degree of separation, or considering what's in front of us and what's been, what options are available, again, to try to focus on minimizing the trauma that our children and youth are experiencing in care.
Thank you, Charito. Angie, from all that you've heard, what do you think are viable solutions, and where do you see the state go from here?
I don't have much to add. I feel like I'll just be repeating what others have already said. And I'm glad that we've got so many places in California where we're having these conversations day in and day out. I think what we're really trying to do right now is figure out how to more effectively use the tools that we have in our toolbox already. So I think we've done a lot in California. I think we've got a lot of resources. I think we've got a lot of innovation, but we need to have sort of those solutions across the system of care. And so I think, you know, the Complex Care Steering Committee that we have in California, where we bring all of those system partners together every month in order to try to figure out, like, how do we more effectively have a shared approach to how we're going to truly do trauma-informed care in California, and have it be first and foremost about, you know, being through that trauma lens, through that understanding of what that young person needs, and putting that young person's needs at the center, not putting the placement at the center, not putting the system at the center, but putting that young person at the center of the solutions, is more and more where I feel like this conversation has always centered, but is centering much more concretely around, like, what does that actually mean? What does that mean in terms of assessments? What does that mean in terms of services? What does that mean in terms of how we structure our systems? What does that mean in terms of the connections between our systems? And, you know, I think it's necessary to go through these, like, sort of painful first steps of reform to get to this level of conversation, and then hopefully to get to true solutions that are truly trauma informed. And so I would say we have to just keep coming together in the partnerships that we've created and continue to expand upon those partnerships. I think we've got excellent folks in California trying to solve these problems, some of which are on the screen right here. And I just deeply appreciate the conversations and the partnership, and, you know step by step, we continue to get there.
Thank you, Angie. And I'd like to thank all the panelists for participating in the rich discussion. Now I'd like to continue with a Q&A session for all of the attendees. You can start by typing in your questions in the chat, and then I'll turn it over to MJ, who will be leading the Q&A section. And just lastly, thank you again to all of our panelists, the Foster Together Network, Pritzker Foster Care Initiative, Center for Strategic Partnerships, Big Orange Splot, and Raise a Child for bringing this panel here today.
Thank you. Thank you so much. Again, thanks to all of our panelists. Thank you, Tyler, our moderator from the California Alliances. As he said, we're going to go into Q&A now. We're going to pose some questions to our panelists. Feel free at this time to still continue to bring those questions in, and we'll make sure that they get answered. So let's begin. I'll start with two questions that were addressed, but we want to make sure that they're spoken aloud for everyone. And the first was from Mary Vincent. She said, how have existing group homes that serve highly complex youth without the IMD issue been able to do so? I know it's come up in the context of the QRTPs in Georgia. I assume because Medicaid isn't being billed for it. And I think, Diana, you answered that question. I'll let you take it.
Okay, so so essentially the IMD rule prevents us from using Medicaid funding while that youth is in that IMD placement. So for their physical health, their mental health, anything that would normally be supported by Medicaid cannot be paid. So in California, for example, the residential placements often come with clinical treatment services that are usually billed to our Medicaid program. So we can't do that if the institute is falls under IMD rules. We could still pay Title IV-E or even state general funds, and that's how some states are approaching it. And so that's how they can get some of those sort of supports and services and placements. And Lizette is the expert here, so I'm sure whatever I've missed, she will cover.
Well, I think there's, I think it's hard to say that anybody's an expert in IMD because it is so varied state by state. But I want to add to that question, and it was a smart question. It was the right question. So IMD determinations, while there is high level guidance from the Centers for Medicaid and Medicare Services, it's a state by state, facility by facility determination. And quite frankly, some of that is based on the risk tolerance of various states. The participant who asked this question is from Georgia, and she said, well, we've been serving these kids. How have we not had the IMD issue already? I would say perhaps some of that is luck. I would use Minnesota as an example. So in Minnesota, they were serving kids similarly and to the way it was described, right? And facilities that overall have more than 16 beds. How are they doing that before? And they thought they were doing the right thing until there was an engagement with CMS starting back in 2018. And they realized that many of their facilities that they didn't identify as IMDs actually were. And so, that's part of the challenge. Another part of the challenge is kind of relating back to a point that Angie made earlier about, yes, we want to see young people served ideally in small and in individualized settings. Part of the challenge with the Institution for Mental Diseases rule is how to count to 16. And that seems like it would be an easy question to answer, but it's not. Real quick, in one state, there's an example where one of the points of pride for one of the leading agencies, one of the leading QRTPs in that state is that children are served in small settings. In homes where there's only up to 4 children with live-in staff, it's very family style. But there are like 5 of those homes on a campus. They also have a psychiatric residential treatment facility on the campus. They're exchanging staff because they got that psychiatric expertise. All of that meets the definition of an IMD. And so that's part of the challenge with this whole conversation. How do you count to 16? Which seems like it should be simple, but it's not. And how are different states interpreting this? And different states are taking different approaches right now. California is aggressively identifying which organizations would qualify as IMDs, and a couple other states are going through the same process. Missouri just sent out memos to facilities this past Friday, and I mentioned Indiana earlier and some other states that have already gone through this process. Some states aren't dealing with this issue at all, and so a lot of variation there.
Okay. Lisette and Diana, thank you for your answer to that question. Brenda Johnson expressed that she'd like to become a foster parent, and is she in the right place? I will respond if Rich doesn't want to jump in and say that Raise a Child can help you with that. Please go to raiseachild.org to sign up, and their team will reach out to you ASAP. You can also call them at 877-417-1440. Okay, so we'll move on to the questions that are still open. Diana Flags asks, the IMD exclusion impacts both substance abuse and residential placement, in addition to other non-child welfare services and supports. Is there any pending federal legislation in process? And is this legislation likely? Anyone can answer.
I can jump in and then let anybody else weigh in. There is a piece of bipartisan bicameral legislation that's been introduced to try and address this issue. It's called the Ensuring Medicaid Continuity for Children in Foster Care Act of 2021. I am not going to read any crystal balls on this call to try to say whether or not this will go through. But I will say there are lots of discussions about trying to find some sort of a legislative solution to this issue, because it is an ongoing challenge. And I will say that this is one piece of a larger conversation related to Institution for Mental Diseases exclusion, which is part of what complicates this. There are several other pieces of legislation that broadly deal with IMD. The bill that I mentioned is narrow to qualified residential treatment programs because of all of the protections that QRTPs afford. I think you've heard people list that there's mandated aftercare and nursing and trauma-informed care and family engagement and all these other things that protect against institutionalization, which I think make QRTPs different from a lot of the other facilities that serve children and or adults in various systems.
Thank you for that, Lisa. Okay, the next question is from Alex Morales. Is there a plan to pilot and expand innovative models like Mockingbird for enhanced family resource family services, support to improve care, stability, and support of foster youth, and its power to also enhance recruitment and retention? We need a funding model to support this model. Anyone can answer?
Well, I'll start off. we love the Mockingbird model. And if you may recall in the FFPSA that there was a little bit of money provided for foster parent recruitment, retention, and support efforts. In California, we made a significant investment upfront when we implemented our CCR into what we dubbed as FFPers. We love our acronyms here, by the way. So foster parent recruitment, retention, and support was the name of the program. We just, in fact, reestablished it through sort of another mechanism with additional funding. We're just getting ready to kick that off. And I completely agree. The challenge with the Mockingbird model is the financial sort of structure of it. So we are able to use our state general fund money, not tied to federal rules, to pay for this caregiver, the central person that's part of the Mockingbird model, to provide that respite and support and ongoing services to their foster parents that are in their communities. But Title IV-E doesn't support that. You might be able to tap into a little bit of Medicaid dollars for it, but then they have to bill to Medicaid in order to draw that down. Our foster parents don't typically do that. We've had problems in therapeutic foster care standing that program up because our foster parents don't prefer to have to sort of do all the documentation and billing in order to draw down those dollars. So I agree it's a challenge, but it's definitely something that we would like to see expanded upon. We have some opportunities in California, but I think on a national level, it would be great to tackle that as a solution.
Any others? Answer, otherwise we'll move on. Okay, the next question came from Ifavella, and it was, how should FFAs pivot in light of less placement need?
Well, I'd love to answer this question too, and welcome others to add on. And I think I expressly used the word pivot, so you might be asking what I meant by that. We enjoy great partnerships in California with our foster family agencies and also many of our group providers too. Many of them are providing family resource center type services, kinship care navigation services, family finding services, aftercare wraparound services. There is so much potential, I think, to work away from the placement. So to Lizette's point, yes, I'm constantly talking to our own child welfare directors and our managers and our staff about not focusing on the placement, but the services, the supports, the needs of our families. So I see in the future, my vision would be that we're working in teams, very light touch in terms of a placement per se, but really supporting families in their homes. We have an opportunity through Part 1 to contract with provider agencies to provide those services in families with their birth families, with their relative caregivers. Working in teams, being part of our child and family teams, a lot of our providers are already there. So I think the pivot is really around the services. And also we still need those resource families, if you will, to provide that coaching, that mentoring, that support, perhaps that respite that a family will need. There's just so much great potential, I think, that there is not going to be anytime soon less of a need for foster family agencies, but I think more of a need, and just looking at that partnership in a whole different way.
Thank you for that, Diana. And I'm just very quickly going to drop some information about the Mockingbird model into the chat for those of you that are interested. Our next question comes from Melanie Golbach. Because you all work in different areas of foster care, you all have different views of what things are successful or helpful to our kids in care. What is the one thing you wish resource families or parents knew or did to support the program, the process, and the kids? I think that's an everyone question. Everybody can chime in.
I can start because it's something we started doing and continue to try to do when we engage new families and even our current caregivers. We get a lot of families at our agency that want to adopt. And because the landscape of the work that we're doing has changed so much over the last few years, it's really about having open conversations about what it looks like. And, I'm always telling the staff that we could just get families to put aside their own sort of preferences and needs and look at the bigger picture and make themselves available to the needs of the children and their families in the moment. That is what they need right now. Being a resource, helping them how to navigate difficult behaviors. For those of us that are kind of on the ground doing this, that sometimes monitored visits can be challenging for families because they don't get to see their kids that often, and it's happy time, and who wants to redirect them if they misbehave, but really that's just a tiny example of how our resource families can better support the relationship that exists between the children and youth that we work with and their families, and whoever that is, grandma, their parents, their siblings, the auntie, whoever it is, but looking at the bigger picture and how they can be a support, which some of you have already mentioned, how they can be a support while these kids are in their care. How do you really make an impact by being that resource for them? I wish more of our families understood that. And that's something, like I said, that we're always trying to encourage them to take a look at. And even just encouraging, like I said, about our adoptive families, to take the risk and just open their hearts and their homes and be willing to be a part of this family's experience for however long or short that may be, which I know is a huge ask. I know it's difficult, but it's something we're always trying to encourage our families to do.
I think I would jump in and say, having my husband and I ran a home, kind of looked like professional foster care. So our biological children were incorporated. We did that for a number of years. And I don't know that the onus for this is on resource families, but I would in general say, in partnership with FFPSA, so foster family agencies, just not only the importance of education, but what a resource parent or foster parent can do to support educational success for a young person. I remember I kind of taught myself all about individualized education plans and learned how to be an advocate in IEP meetings for young people who weren't getting the resources that they deserved, or who were still being excluded from school when they shouldn't have been. And just all of that in terms of learning over time, how to support that young person to advocate for themselves, how to partner with their family members to learn, here's what the expectation should be, and here's how you can engage. I think being very intentional about that whole process as it relates to educational success will lead to better outcomes for young people and families in general. So whatever we can do to support that, I think that's key. And for foster parents or resource parents to come in knowing that's a part of what you can do to help enhance the young person's long-term experiences overall.
Wonderful. Thank you both for those answers. The next question comes from Beth McClooney. In terms of prevention, if someone knows a child is in a threatening position, what does the panel recommend the observer do first?
I think first and foremost that there just does need to be that call to the child welfare system, to that CPS hotline. Certainly we will try our best to link them to prevention services. Ultimately, under the law, it is up to the agency that is the Title IV agency. So in California, it's counties, in some states, it's a state administered system, but we're, to determine who are candidates for those prevention services. But if there is a concern that there's a safety issue for the child, we would want to hear and learn about that and be able to respond appropriately.
Any others? Okay, thank you, Diana, for that. Next question, and okay, I was about to say last question. You guys are starting to pick up here with the questions. All right, from Lauren, and forgive me, the last name DeTore. Diana, you're right that the pivot is so important to providing different kinds of services to families, both biological and resource. A major struggle to that is the way funding works. If FFAs get paid per placement, we can't really pivot while meeting contractual needs and still qualifying for the funding that allows us to remain open. Are there county lead efforts in the works to support us in that pivot?
I would say there are state and county efforts in this regard, again, sort of facilitated by some federal things. So, for example, California is implementing a Medicaid waiver, a Section 1115 waiver that has, starting in last January 2022, opened the door to access for all kids in foster care to EPSDT, or the enhanced, basically the Medicaid services that provide the diagnostic, treatment, and therapy for foster kids. And so now it's not a question of will our kids have access to EPSTT services, but to what services will they have access to? They have to be medically necessary still and all of that. But I think we are finding ways to be more creative in our ability to tap federal resources. We're, as Angie noted, we're looking at the rates for our systems of care, including FFA rates, to see if we can better support those services that are provided through agencies. So we have some efforts underway and agree that if there isn't a child in the placement, it makes it a little bit difficult, but not impossible. And I think we can get creative in our approach to this.
Thank you for that, Diana. Okay, we do have what looks like one more question. This is from Kimberly Zunika. Forgive me if I hacked that. She said, thank you all for coming together today. And her question is, how long do you all think it will take for the foster care landscape to become more therapeutic in nature and provide services at the individual level for youth who are foster involved?
I can take a crack at that, because I do think it speaks to the need for, for federal reform. I do think that there is an opportunity for folks to think about what would need to be the next step federally. I'm talking, completely federally. What's needed after Family First? As I said before, Family First was never intended to be the end all and be all, but there does need to be momentum. There needs to be, a thoughtful and strategic approach to what we can do to address the themes and the goals that we've all outlined here today, but also to really bring what is working in the states to the federal level. One of the really humbling experiences having worked, on Capitol Hill is you really don't know what you don't know. And, and a lot of what you don't know is what is actually working on a granular level in the states. So there needs to be a more efficient dialogue, I think, between, what incredibly committed, smart, thoughtful people are doing on the ground. There seems to me to be a disconnect between that and what lawmakers on Capitol Hill are experiencing. So if there's a way to bridge that gap, I think that's an excellent first step to the next step after Family First.
And I would just add, I don't think that there's a set time that will actually be there, but we are continuing to innovate in this space. I mean, Diana spoke about CalAIM and our efforts to try to make sure that we are fully leveraging the opportunities of how we're structuring access to our specialty mental health services. And so I think there's real opportunities in that space. We've got our foster care model of care work that's continuing to try to really figure out how we can create a model of care within our system that is much more therapeutic and centered around the needs and the trauma of the child. We've got the rates work groups that I talked about, where we're trying to innovate in that space as well. We've got investments that were made in last year's budget to create sort of a crisis continuum pilot and sort of innovate around that model of services. We've got dollars that are flowing to counties now to do some capacity within their own individual systems. And so there's capacity building dollars for counties. We've got dollars that are available to counties to do innovations on a child specific level. So if there's an individual child that has specific needs, there's specific dollars available to counties to sort of innovate on behalf of that specific child. We've got legislation that passed that allows us to create innovative models of care, either at the child or the program level, that are sort of outside our current sort of rate structures, which I think goes to the next question that was just in the chat. So we've got a lot of things that we're working on. We've got a lot of different funding streams that we're trying to implement. We've got a lot of different approaches to innovation. And we've got a lot of places where people come together and talk about how all of those things are converging, and what's working and what's not working, and what can we scale and what do we sort of need to get rid of. And so I don't think that there is I think we make improvements all the time. I think we're moving in that direction as a system and as a field. But I don't know, like when you ask like, when will we be done? I don't know. I've been in this space for 20 years and it feels like it's just a constant work in progress. Continuous quality improvement is sort of the way that we approach the work.
Thank you for that answer. Absolutely. Well, this will be our last question, and it comes from Camille Bailey, and she says, in California, CDSS is funding lots of pilots for new models of care, but the grantees have to create these new models within the confines of existing funding structures and program requirements. Has the state considered offering temporary waivers that are closely supervised to allow folks to pilot new models that are radically reimagining how care can look?
So I think that's an interesting question. I just mentioned the legislation that was passed that allows for us to sort of create innovative program models and innovative models of care at the child-specific level. But I think what we're trying to figure out is where that runs up against the licensing rules. And I think that that's what the question gets to, is sort of the intersection between how those programs are licensed and then how they can actually innovate. And so we are continuing to try to look at, like, where do those two things create conflict, where we're not really enabling us to do the kind of innovation that we really want to be able to do, but recognizing that those licensing rules exist in order to keep kids safe and to like make sure programs are delivering the level of services that we need them to deliver. And so there are some inherent tensions there, but absolutely want to continue to innovate in that space. We've learned a lot from what we're doing so far and always interested in learning where else do we need to have flexibility within the system in order to design programs that are accomplishing our goals without sort of letting go of child safety and making sure that we're delivering sort of the high quality of services that we want to deliver.
Thank you so much. Thank you. I want to say this time we are at time. Thanks to all of our panelists for such an insightful meeting. We want to encourage you all to join us next Wednesday at 9 a.m. Pacific or noon Eastern for the second session of the Foster Together Network, the Solution Series, and it's entitled The New Recruit, Supporting Resource Parents for Today's Need. Please mark your calendars and join us. And to everyone, thank you all and have a wonderful, wonderful weekend.